Two patients hit the emergency department doors at the exact same time. Both are in respiratory distress. Patient A has a history of asthma. They look exhausted, their eyes are heavy, and strangely, their chest is completely silent. There is no audible wheezing. Patient B has a history of COPD. They have a harsh, productive cough, and the bedside monitor shows an oxygen saturation of 91%. You have seconds to decide. Which patient requires the immediate, life-saving intervention? Shortness of breath is a subjective symptom. It tells you someone feels terrible, but it doesn't tell you the mechanism causing it. Respiratory failure, on the other hand, is a measurable physiological collapse. To separate a chronically stable patient from an acute emergency, you must apply the ABC framework: airway, breathing, and circulation. Without this hierarchy, clinical symptoms are just noise. Applying this framework isolates the immediate threat, allowing you to accurately prioritize care and prevent patient death. This diagram compares a normal to an asthmatic bronchiole. Asthma is an intermittent, reversible airflow obstruction. During an attack, three mechanisms trigger: mucosal lining swells, smooth muscle constricts, and excessive mucus is produced. The airway is clamped shut. Early on, the patient hyperventilates to compensate for the narrowed passage. This blows off carbon dioxide, creating a state of respiratory alkalosis. As air is forced through those tight spaces, you hear audible wheezing. But as the patient tires from the effort, carbon dioxide levels begin to rise, pulling them into respiratory acidosis. The wheezing fades. This creates the paradox of the silent chest, a sudden cessation of wheezing paired with extreme fatigue. A silent chest does not mean the patient is getting better. It means the airway has completely collapsed. No air is moving, and complete respiratory failure is imminent. When a patient enters this state, known as status asthmaticus, the first mandatory nursing action is to administer unrestricted, high-flow oxygen via a non-rebreather mask. The immediate pharmacological priority is to force the tight airway open. You administer a short-acting beta agonist, or SABA, like albuterol, to force rapid bronchodilation. Once the airway is open, the secondary step is delivering systemic IV corticosteroids to halt the underlying inflammatory cascade. In an acute asthma exacerbation, the immediate threat is a complete airway blockage. All clinical interventions must prioritize forcing that airway open before addressing any secondary concerns. This compares a normal to a barrel chest. In COPD, destroyed alveoli trap air on the way out. Constant hyperinflation flattens the diaphragm, forcing the patient to rely on neck and shoulder muscles, permanently expanding the chest's anterior-posterior diameter. This chronic air trapping creates a metabolic state of hypercapnia. The patient permanently retains excess carbon dioxide in their bloodstream. This graphs SpO2 against PaCO2 to illustrate the oxygen trap. A COPD patient's respiratory drive relies on low oxygen, not high carbon dioxide. Administering 100% oxygen erases that hypoxic drive. They stop breathing. CO2 accumulates rapidly, causing respiratory arrest. Therefore, oxygen administration for severe COPD requires a strict clinical boundary. You cap oxygen delivery to maintain an SpO2 between 88 and 92%. Because you cannot flood a COPD patient with oxygen, you must rely on non-pharmacological interventions to manage their breathlessness. You position the patient upright in high Fowler's or a tripod position. Gravity pulls the abdominal organs downward, relieving pressure on their flattened diaphragm. You then instruct the patient in pursed lip breathing. Exhaling slowly against the resistance of puckered lips creates back pressure inside the lungs. This pressure splints the airways, keeping them open longer and allowing trapped carbon dioxide to escape. Asthma demands maximum oxygen to save a failing airway, but COPD is a mechanical breathing failure where excess oxygen becomes a lethal nurse-induced trap. These types of complications are called iatrogenic threats, issues directly caused by medical interventions that create entirely new ABC risks. Consider a bronchoscopy, where a camera is inserted to visualize the respiratory tract. To perform this, the patient's throat is treated with a local anesthesia. That anesthesia temporarily paralyzes the muscles controlling the gag reflex, creating a massive, localized airway vulnerability. The strict nursing priority is to physically verify that the gag reflex has returned before resuming oral intake. Skipping this assessment guarantees aspiration. Similarly, look at a thoracentesis, a procedure requiring a needle to be inserted into the pleural space to drain fluid. This introduces a significant breathing vulnerability, the inherent risk of accidentally puncturing the lung tissue with the needle. Post-operative monitoring targets this specific risk. You assess for diminished breath sounds, severe dyspnea, and tracheal deviation, the classic signs of a pneumothorax. Standard medical orders never override physiological realities. Verifying a patient's airway and breathing safety is a mandatory prerequisite to every subsequent nursing action. Let's return to our triage scenario. On the left, patient A, history of asthma, presenting with a silent chest and drowsiness. On the right, patient B, history of COPD, an SpO2 of 91%, and a productive cough. Filtered through the ABC lens, patient B's data makes sense. For a patient with chronic lung damage and a blunted hypoxic drive, an SpO2 of 91% and a productive cough align perfectly with their disease baseline. Patient B represents an expected, stable chronic breathing condition, requiring routine, non-urgent management. Patient A is entirely different. The lack of wheezing combined with systemic drowsiness indicates the silent chest paradox. Their airway is completely obstructed. They are physically exhausted and in the final stages of the deterioration cascade. Patient A is the immediate priority. They require emergency intubation and high-flow oxygen to survive. Whether sequencing albuterol before steroids, restricting oxygen for a COPD patient, or withholding water after a bronchoscopy, the logic is identical. High-level clinical nursing is not about memorizing lists of symptoms. It is the relentless, critical application of the ABC framework to halt deterioration before it becomes irreversible.